I think the issues with respect to healthcare and healthcare reform is very relevant, and it impacts us as well as our clients. And I'd like to introduce Ron Lang, our next speaker. And the title of this session is It's 2014. So what happened to your healthcare coverage? Ron is the Chief Executive Officer of CalCPA Protect Plus, which is CalCPA's group insurance trust. He has over 25 years of experience in healthcare operations, systems, and finance. He's written numerous articles published in industry periodicals, and he's been a speaker and panelist at conferences, including those sponsored by the Insurance Accounting Systems and Association. He is a certified management accountant and a graduate of Michigan State University. So please welcome Ron.
Thanks. Good morning. Before we get to the agenda, I just want to set a little bit of groundwork for what we're going to talk about this morning. Where I call the group insurance trust, or the group insurance trust view of the market. You heard a little bit about my background. Well, the group insurance trust, for those of you that are not familiar with it, operates very similarly to a mutual insurance company. So our members are called participating employers, and so our policyholders, in essence, run our organization. But in the state of California, we operate as an insurance company. We're an admitted carrier, so we're subject to all of the Affordable Care Act regulations and all of these regulatory changes that we've run into. So although in a little bit smaller version, we can speak, or I can speak to the general goings-on in the insurance market that have happened since the Affordable Care Act's been passed. So today I'll be able to give you some real-life examples from our data to try to put some of the abstract terms in context. You know, the Affordable Care Act, when we joke around and say it's an emerging law, and I think almost every morning when you turn on the news, you're not sure if there's going to be a new change to the law. In preparing this presentation, I went back and tried to get a list of all the law's changes. The Wall Street Journal a few weeks ago published a list. They had 38 items on it. Some other organizations add some court cases that have changed the law, and they get it up into the 40s. So since the law was passed about 4 years ago, 38 or 40 times various entities have altered the law. And when I sit around the market and chat with my peers, the one thing that we wish would happen is that the regulators or the politicians would just set the playing field so we know what to do, and then we can do it. But it's been one of these musical chairs where we have to keep adjusting, and those adjustments have an effect on our populations, folks trying to understand what's going on. And then the scope for today, for the most part, I'll be talking about California and the federal regulations. Each state has different adaptations of the Affordable Care Act, and I'm not sure anybody's an expert in all of those. We're very familiar with California, very familiar with the federal regulations, so we'll try to stick within those. So then to the agenda. So I'm going to talk about what happened in the Q3 and Q4 of last year. There was a lot of displacement and upheaval in the market. And then we'll go into some things to watch for during this year going into next year. I think the things that you'll be seeing hit the news. And then what's ahead. Last year I spoke at this conference, and I don't know if I gave predictions, but I shared what we thought was going to happen in the market. And for the most part, we hit most of them pretty close. And we'll do that again today. We'll give you some ideas on what we think is going to be happening going into 15 and beyond. So back to the end of last year, the end of 2013. The attention was on the individual market. The exchanges were opening up. The large employer mandate that was supposed to go into effect was delayed. And the small employers, at least in California and many states, were somewhat buffered from what was the upheaval that was taking place. So the real attention was on the individual market. In the small employer market, in California, we already had things like guaranteed issue and some of the rate restrictions or rate controls that were in place that the federal laws were bringing into place. And we also had and I'm going to talk about this in detail later, an early renewal tactic or program that came into play that buffered what was going on in the small group market. So really the attention was on the individual market. And what was that attention? The cancellations. Everybody was getting their policies canceled. Various organizations were reporting 5 million cancellations, all the carriers issuing cancellation notices. And some of the regulators and the politicians were saying, well, we don't understand why insurance companies are canceling policies. And the insurance companies were saying, well, we're being forced to cancel policies because of the regulations. So here at the bottom, a health insurance policy, except a specialized health insurance policy that is issued, amended, or renewed after January 1st, shall provide for. And the regulations, California SB 639 and the Affordable Care Act, in many of the provisions start with that exact sentence and then tell what the mandate is going to be after January 1st of 2014. So once again, a policy that is issued, amended, or renewed. If you had a policy that wasn't in compliance, it couldn't be issued, amended, or renewed. Now, I happen to have a commute of about an hour each day, and so I listen to the radio, and you hear people coming on, and they're surmising why these policy cancellations were happening. And one of the things that came out is, well, they have bad policies or crappy policies. I think there was a lot of saying, and the government put in a set of mandated benefits, the 10 essential benefits in the individual and small group markets. And they certainly did mandate different levels that were not normal in most insurance policies. The two main ones out of the 10 were the substance and mental abuse areas, and one that I'm not aware that hardly any insurance policies that I'm aware of had pediatric dental and vision benefits as part of their major medical plan. Those were required to be in the new individual and small group plans going into 2014. So it wasn't necessarily that your coverage was bad, it just didn't meet the government mandates. There was also new limits on deductibles and out-of-pocket maximums. The federal government had actually issued a safe harbor on deductibles and out-of-pocket maximums going into 2014 to give some relief in this area. California, in its infinite wisdom, didn't go along with the federal safe harbor, and they implemented the regular regulations as is. What that caused was everybody had gotten their plans lined up to meet what we thought were going to be the federal regulations with the safe harbor, and at the last minute, California, at the end of September, passed SB 639. It didn't have the safe harbor provisions in it, and everybody had to refile their plans right at the last minute to make them compliant with the California version of the Affordable Care Act. And then the last one that was really disruptive to the individual and small group market were the metallic tiers. And I'm going to talk a little bit about that. But the federal regulations introduced a term called actuarial value, and it makes all plans have to line up within certain metallic tiers. So actuarial value is a concept that the Affordable Care Act introduced where they evaluate insurance plans and they want to put into categories bronze, silver, gold, platinum, and each plan has to be within plus or minus 2% of those categories. The example I want to show, our Group Insurance Protect 15 plan, when we started working with that last year and we used the actuarial calculator, it had an actuarial value of 85%. Well, you're not allowed to have an actuarial value of 85%. You can have 90 or 80, but you can't have 85. Now, our Protect 15 plan is not a bad plan. In fact, it's better than a gold plan, not quite as good as a platinum plan. It had an 85% actuarial value. We were not allowed to have that plan in the market at an 85% actuarial value. We had to change that plan. We had to either take it to 80 or we had to take it to 90. We had to amend the plan, change the plan. So those kinds of disruptions in the market, when we say, there were plans that weren't compliant, This is almost everybody's plan. It was just the luck of the draw if you had a plan that lined up at 80, 90, 70, or 60%. Almost every plan had to be altered in some way to get it into those categories. So when folks were getting their renewals last year, or they were out shopping for plans, and there were all these benefit changes and related premium changes, a lot of it had to do with trying to line up these plans. And of course, then we had to add in some of the mandated benefits that I mentioned, and that affected the actuarial value, and so we had this upheaval, or what I call displacement in the market, that this was causing. So about this time last year, we started hearing that insurance companies were talking about offering early renewals in the small group market. And I'll go back to my statement before. A health insurance policy that is issued, amended, or renewed on or after January 1st, 2014. Well, what if we renew the policy in December instead of January 1st? Well, we can, in essence, buy or operate under the 2013 regulations for one more cycle, 12 more months. These things were announced to the market. The regulators looked at it and said, well, yeah, the law allows an early renewal. The insurance commissioner in California came out and said, you know, he doesn't fundamentally agree with it, but that's the way the law is, and he wasn't going to oppose or propose any changes to the law. So every carrier that I'm aware of in California, and many nationwide, offered small groups early renewals on their coverage to be able to retain the 2013 rating rules for one more year. We have obviously a number of speakers today, and these rating rules and the things I'm going to be talking about here are covered in detail in some of the other folks' presentation today. And so I'm going to try to give you the background and get to the points I'm going to make, and not have you repeat presentations here. We'll see if I can pull this off. So the Affordable Care Act mandates some new rating rules, and those are replicated by California legislation. These aren't what I would call actuarially determined. In other words, we have actuaries that work for us, and they figure out premium rates, and usually they work in 5 or 6 decimal points and take things out to extremes. The government has come up with what they call an age band curve that specifies how much we charge people at different ages. It's a curve of relativities that they charge. The actuaries used to determine what that age band curve was, and they mandated that curve is a 3-to-1 ratio. So our 2013 rates, typically they run a 5.5 or 6-to-1 ratio. So if somebody's 20 years old and their rate is $100 a month, a 65-year-old person's rate might be $600 a month. And under the new age band curve, that 20-year-old's rate is $100, but the 65-year-old's rates can't be higher than 3-to-1 or $300. So they've crushed this age band curve into the middle. There is pending legislation in Washington to do away with the age band curve or the specified relativities. With the politics going on in Washington, I wouldn't expect that we'd get any relief on the age band curve, but people have recognized that is very disruptive, and it might not be the best thing to have, but it is what it is, and we have it today. Also, unisex rates are taken out of the mix. It's a fact that older men, let's say age 50 and above, are heavier utilizers than women, and younger women, 20 to 40, are heavier utilizers of health care and cost more than men at that age groups. And our rates used to reflect that actuarial fact. So now unisex rates, men and women are charged the same, and they're blended together. And then we've altered the rating areas. We used to have 9 rating areas in the state of California. It now goes to 19, and they're clusters of counties that are dictated by Sacramento. And I'm going to show some examples of that in a minute. Family tier structures. In the small group and individual markets, we used to have employee-only rates, employee spouse, employee plus children, and family rates. And those were the tiering structures that we had. Under the Affordable Care Act, each person is rated as an individual, and the rates are built up. So if you have a family of 5, the husband and wife and the 3 children are all age rated separately and put together into a family unit. So you can have families of 4 or 5 will be rated differently, where under the old method they were rated the same. Or if somebody had a child that was 21, say away at school or still on the plan, they're going to be rated higher than a family that, say, had a 15-year-old. And I'll show some examples of that as we go through. The other thing that it did is eliminated what we call Medicare secondary and primary rates. So if we had somebody on a health plan and they were over age 65, if they were enrolled in Medicare, we could charge them one rate, and if they were not enrolled in Medicare, we could charge them a higher rate. The Affordable Care Act, because of the age band curve, effectively eliminates that, and so there's not an incentive for workers that are above 65 from a financial standpoint on the premiums to enroll in Medicare, and so that brings that population into the insured pools. And it eliminates the age band. So in California, we used to have age bands. So if you were 30 to 40, 50 to 55, you operated inside that age band. Now everybody is age rated at their age. So you get a rate increase every birthday or every year now. So there's a different age rate from 47 to 48, from 48 to 49, where that used to be all within one band, and you wouldn't have an increase until you got to age 50. So those are the main differences in the rating rules. Let me go back to these rating areas. So on the left here is the 9 rating areas that we were using in 2013. And I don't want you to be able to, you don't need to see all the details here. I just want to make a couple points. If you look, so I don't fall down the stairs there. In the middle here, the purple is Monterey County, and you see right above that is Santa Cruz County in the green, and we have those as 2 different rating areas. And if you were able to see the numbers, you'd see that Region 1 is Monterey County with a relativity of 1.16%, and Santa Cruz County is in number 3 at 0.82%, and that's how we had that divided up. Going into 2014 on the right, if you look at those 2 counties, you'll see that they're together. So the regulators in California have put those 2 counties together. So if you were in Monterey County, which is a relatively expensive county at 1.16, or at least the relativity that we had it at 1.16, that's now blended in with a county that was at 0.82. So if you're in Santa Cruz County, most likely your rates are going to go up a little bit because you're now blended with a higher cost area. And if you're in Monterey County, your rates are going to go down a little bit because you're blended with a lower cost area. So they've drawn these boundaries. Once again, it'll create disruption. It creates differences in rates. So we have these different rating factors that are mandated by the Affordable Care Act. And I'm going to go back here. So we've got the age band curve, we've got the unisex rates, we've got the rating areas, we've got the family tier structures. So what we did at the trust, at Protect Plus, is we took our entire population of members and we ran them through the new rating rules. And our population is about the same as any other carriers. In other words, we're not particularly older or younger than the general population in California, and we're spread out amongst about the state. It's a credible population group. So we didn't change the medical rates at all. All we did was change those new rating factors. And here's the results. So we had, for example, if we look at the plus 35 to 40 range, 4% of our population's rates were going up between 35 and 40% by just changing the rating rules. And we had some folks, 5% of the population were going down 25 to 30% just because of the rating rules. We didn't change the underlying cost of the medical component of the premiums. We just changed the difference in rating rules. Now, from my old statistic educational background, things tend to operate in bell-shaped curves, right? We would expect when we change the rating rules that everything would kind of gravitate around 0 and maybe have some tails going out. And we were surprised when we did this that although there is a little bit of a hump in the middle, +5 to -5, 8% of 16% of the population's in the center. It's a relatively flat table, and it tears off at the sides. When I wrote an article about this last fall, and I think it's published in various places around CalCPA, about displacement and about how this occurred and the effects that it has on population. So somebody opens up their renewal notice and they have a plus 40% rate increase. They probably say, wow, that evil insurance company is raising my rates 40%. Well, we didn't have a whole lot to do with it. We didn't change the medical rates. All we did was apply the new rating rules here. And the same token, somebody opens up their bill and they have a negative 25%. Wow, this is pretty good. My rates went down 25%. It's just the rating rule changes. So how did those what brings that about? Well, when we looked into the details, if you had a family with older children, let's just say that we had 3 adult children on a plan, where we had them rated as a family unit. Now those 3 adult children are getting rated as adults, and the rates go up. So almost all the folks that we looked at in those categories with the big rate increases, they had big families with older kids. And the ones that had the large decreases, typically those were older couples, folks in their mid-60s that were at the far end of that age band curve, and they were getting the benefit of the 3-to-1 age band curve. So moving along to the things to watch out for going into next year in the small employer market. When we did the early renewals, the folks that were getting the decrease, typically they already have their 2014 rates, right? They're getting a rate reduction according to the new rating rules, and so they're already playing under the 2014 rates because they benefited from that. The folks on the left that were getting the increases, they're the ones that wanted to early renew in December and buy the old rate structures for 1 more year, because then they're just getting medical trend instead of getting these sharp increases. So when we get to next fall, all these people on the left they're going to get their renewals, and those rate increases are going to be realized. The new rating rules are going to be in place, and they don't have any place else to go. They can't change carrier. They could change carriers, but the new carriers are going to be rating them the same way. Since that's mandated across all carriers, it's going to be the same thing. And so I think you'll start hearing in the news that small groups are getting large rate increases. And once again, it doesn't have anything to do with medical trend. It has to do with the rating rules. And it's going to be about 50% of the small group population. And it was buffered from that last year. So about 50% of the groups. In the small group market in California, we also had a thing called risk adjustment factors, where we could alter rates between plus 10% and minus 10%, depending on a group's demographics and health. That's been thrown out by the Affordable Care Act. So the groups that all had from 0.9 to 0.99, they have to, in essence, get up to 100% because the risk adjustment factors are eliminated. So some of those folks have a built-in additional 10% rate increase that's coming through to them. That wasn't the data that I showed for the group insurance trust. We didn't use risk adjustment factors, but the other carriers in the state do or did. And so that's another factor that will force rates up for some people and also force rates down on others. Younger people in larger families, if someone says to you, hey, I just got a big rate increase from my health insurance carrier, ask them how old they are and how many older kids that they have, and I think you'll probably see what the answer is. The rating area changes. We're seeing a big movement in California. Northern California is getting relatively more expensive for medical care than Southern California. I think the reason, I've lived in both, and I think the reason for that is that Southern California has more competition. We have in Northern California, there's pockets that have somewhat of monopolies on hospitals and doctors' networks, where in Southern California it's a little bit more competitive. And we're seeing sharp increases in providing the cost of care in Northern California, and that's reflected in the rating area changes and the relativities. And then the compliant plans, as we've had to add higher benefit levels into those plans, we do see higher premium levels. Another thing to watch for 2014 going into 2015 is we had a population of uninsured people in 2013. And the uninsured are in two categories. They were people that had pre-existing conditions that could not obtain insurance in the market, and the Affordable Care Act addressed that by waiving pre-existing condition limitations so that anybody can enroll in a health insurance plan regardless of their health status. And then the second category were people that couldn't afford coverage, and I break that into two categories of people that truly couldn't afford the coverage and those people who chose not to afford it. I think we all know folks that are well enough off to buy health insurance and they choose not to buy health insurance. So I put those into the category of choose not to afford it. So the Affordable Care Act set out to provide insurance to approximately 47 million uninsured folks. And in the first couple years, and one of our speakers later today will be talking about the individual mandate penalties, so I'm not going to go into the details here, but in years 1 and 2, they might not be enough to really compel people to buy insurance. They get stronger as the law gets implemented in years 3, 4, and beyond. But in the first couple of years, the penalties are probably not as much as the health insurance premiums are going to cost in most instances. So I apply the human nature effect to this and say, well, if I'm not being forced financially to buy something, out of those 47 million people, who are the ones that are buying? And I think the White House announced 7 or 8 million people have enrolled nationally through the exchanges. I'm going to go out on a limb and say, if there's 7 million out of 47 million, those are probably, on average, a little higher utilizer folks than the ones that didn't buy, right? So if you have a need for health care, you have the opportunity to buy it, whether it's because of a premium subsidy or because of a pre-existing condition limitation that you had, you're probably the ones that were showing up first, and later on might be the people that are actually forced to buy it by mandate penalties. Approximately 90% of the families, the family units, and the Affordable Care Act all operates under family household income requirements, are at 400% of the federal poverty level and below, and that's the upper level to receive a subsidy. I'm going to show some examples of the subsidies here in a minute so that you can get an idea of how those are being applied to understand how the Affordable Care Act works. So the Affordable Care Act provides subsidies up to 400% of the federal poverty level, and I think this chart is using 2012's numbers. It might be 13, but the whole idea, don't pay attention to the numbers, it's how the numbers work. And I'm going to be focusing in on the 250% of the federal poverty level in my example so that you can get an idea of how these subsidies work. So in my example, at 250% of the federal poverty level, the person was making a single person making around $28,000 a year. They're required to pay 8% of their income for health insurance premiums. And that comes out to be the $22.56, or about just a little below $200 a month for a single person. That's the way the subsidies are calculated. It's based on the contribution that the person has to make to buy their health insurance premium. So in this chart, we've got our $28,000 income. We've got the $188 a month that they have to pay, which was 8% of their income. And then that subsidy is applied. To calculate the subsidy, they take the lowest cost, second lowest cost, silver plan in your particular region. So if you, back at the beginning, we had those metallic plans. So they base it off the silver plan, and it's the second lowest cost silver plan in your particular region. So we already saw that we have 19 rating regions. So each one of those rating regions will have a second lowest cost silver plan. It could be Kaiser, it could be Blue Shield, it could be whatever carrier is the second lowest cost one. They apply that premium, they apply the amount that you have to contribute, and once again, the $400 is just an example to make this work out, because it would be different depending on how old the person was. They're going to have a different age. So I just put $400 in there as an average. And so in this example, the government would be applying a $212 subsidy. And you can see how that subsidy would be different for every person, or almost every person coming in. Different regions, different ages. Everybody's going to have a different subsidy amount that's calculated, and that would be across the country. So when we start calculating, well, what are these subsidies and how are the subsidies? It's very difficult to get a handle on how much the subsidies are, because everything's based on the contribution that the people have to make to their premium, and then the cost of the silver plan. When the government set this out, they specified the federal poverty levels, they specified the percentages, but 4 years ago they had no idea what the second lowest cost silver plan in each region was going to cost. In fact, we didn't even know that until going into last summer, and that's when we finally knew what the amount of the subsidies was going to be. But why I've gone through all this is I want to point out that the subsidies, or the contributions, while they're not necessarily exactly tied, but they relate to general consumer price inflation. So the federal poverty level and in people's incomes behave along the lines of the consumer, or of general inflation. And I know they don't tie exactly, but they behave that way. The column on the right is the premium cost of health insurance. And those numbers behave according to medical inflation. As the cost of, our first speaker was talking about the explosion in the cost of medical care, medical inflation. So we have subsidies, and I call this an open-ended subsidy, because we have the specified amount on the left behaving according to general inflation, and the one on the right behaving according to medical inflation. And when the Affordable Care Act was first passed 4 years ago, I thought it was odd that nobody knew exactly how much it was going to cost, and there was great debate that well, you know, the budget office estimates it at this, and this group estimates it at that, and nobody knew exactly how much this was going to cost. This is the reason nobody knew how much it was going to cost, because nobody knows how much the subsidies are, and we still don't know exactly how much they are. So if we go on the slide before, we're talking about medical inflation. So here's a chart that starts in 1999, and the blue line is single premiums, and the red line is family premiums. And we take that from 1999 through 2012, and we calculate the inflation if we want to use that as a proxy for medical inflation. And single coverage premiums have gone up 155% over that period of time, and family coverage has gone up 170% over that time. The consumer price index inflation for that same period of time is 38%. So you can see how medical inflation is outpacing consumer inflation by quite a bit. And so if we go back to this chart, I'm going to go out on a limb and predict that over time, that right-hand column is going to keep outpacing, and the subsidies are going to continue to grow and grow and grow. As medical inflation outpaces consumer inflation, we're going to see the subsidy amounts continue to go this way. And I don't think I'm going out on a limb much on doing that. So with the overall premium costs of the Affordable Care Act, we've got some basic economics at play here. And at CalCPA Day up in Sacramento back in January, the president of the Cal Chamber of Commerce spoke, and he mentioned this phenomenon in his speech, where we've got these two populations entering the insured rolls. We've got what I call above average utilizers, so the folks that had pre-existing conditions that are coming into the insured populations. And then we've got the population of people that are receiving subsidized premiums, and I just gave a very detailed example of people that are getting subsidized premiums. Those two populations are going to get passed through the insurance system, and those costs are going to be absorbed by the remaining population. So the overall costs are going to increase. Some of the people are getting subsidized premiums. Some people are getting higher utilizers. The remaining folks that are in the system that let's just say were there in 2013 are insured but are not receiving subsidies. You know, the old economic model, there's no such thing as a free lunch. Those costs are going to go up and they're going to be reflected in higher premium costs. There's also, in addition to those two populations coming in, there's a lot of new taxes in the Affordable Care Act. And the ones that are going to be reflected in premiums are taxes on pharmaceutical companies, on medical devices, and taxes on insurance companies. Those taxes are going to be embedded into the medical costs or the medical premiums, and they're going to get passed on to the final consumers. And the people that aren't receiving subsidies are the ones that are going to pick up those taxes. And those taxes then go to apply to the subsidies and to the other administrative costs that are going on to run the Affordable Care Act. This chart shows, starting in 2010 when the Affordable Care Act was passed, there's taxes that are coming in over time. The last one on top, the excise tax on Cadillac health plans, I'm going to talk about that a little bit later in the presentation. But this gives you an idea of all the taxes that are coming through. And you know, once again, going back to your general economic models, whenever there's a tax, who pays for it? Typically the end consumer pays the tax. Somebody has to pay these taxes, and it's going to be reflected eventually in premiums and in some of the other taxes that are going to go through the Affordable Care Act. The individual market success, once again, our first speaker talked that it appears that the exchanges work or could or may work as we go forward. But we hear in the news that the key to the Affordable Care Act success, or the key to the exchanges working, is that young people need to enroll. And although it's true that younger populations in aggregate tend to be healthier than older populations, I think the key for the Affordable Care Act to work, or the exchange to work, is that healthy people need to enroll. All right? I mean, we know that older people pay 3 times the amount of premiums than younger people from our age band curve. If older healthy people enroll, which I think is more likely, because I think older people would cherish the opportunity to get health insurance more than, say, younger folks that haven't figured out their mortality yet. That we may, if we can get populations of older healthy people healthy people no matter what their age to enroll, that could make the out of that 47 million people, that's how we'll really dictate the success. If only the higher utilizers enroll in the plan, costs are going to go up, everybody's premiums are going to go up, and then you know, who knows what's going to happen with those situations. Once again, looking ahead to the end of next year and the beginning of 2015, it's what I call the tax surprise. So if you're receiving a premium subsidy, and we went through the example on how you get the premium subsidy, going back to our example of somebody who's making $28,000 a year and they're 250% of the federal poverty level, that all seems to work really well. But how did we determine that you were making the $28,000 a year to get that level of premium subsidy? Well, Covered California and all the exchanges, they ask you, how much money do you make? And how much money do you think you're going to make in 2014? Right? So you were sitting in the end of 2013, and you hadn't filed your 2013 tax return yet. You had 2012's, hopefully. And you know how much money you're making, and they say, well, how much are you going to make in 2014? And you take a stab at it, and you say, I'm going to make $28,625. Okay? And you received that subsidy, the $212 a month. When you file your 2014 income tax return before April 15th of 2015, you are going to reconcile your actual income for 2014 versus your projected, and therefore that subsidy. And any difference will be paid on your tax return, plus or minus. So if you make more money, you got a different job that made more money, you worked more hours, all of that would increase your income. You are going to have to pay that subsidy back to the government. So I call it the tax surprise. Now, obviously, if your income went down, you'd get a tax credit back. But what I think is most of the folks that are going to be getting the subsidy, it's not cash passing through their hands. So they're making a premium payment, and the government is paying the health insurance company the subsidy. So they've never seen the cash come through. They made $2,000 more than the $28,000. Now they're going to have to pay back some amount of money on their tax return that they never really saw the cash come through. And that's why I call it the tax surprise, because I think some people are going to be surprised. Congress has recognized that this could be a problem. So they've already passed 2 bills to try to reconcile this problem. The first one had higher limits on it. So anyway, what they've done is said, hey, if you don't estimate properly, we're not going to make you pay it all back. And here's the chart. I'm not going to go through this in detail, but if $47,000, you only have to repay $600. So if you missed by $5,000, you only have to repay $600. My bullet point at the bottom, gaming the system. I mean, it seems to me that, why would you ever, wouldn't you be better off underestimating your income if you're getting a subsidy? Because you might run into one of these limits and get, free money, okay? So we'll see how this plays out. But I think there's just going to be, I think a lot of people will estimate what they really think it is. And they're going to, the economy is doing better, and people tend to make more money year after year. And you're looking at an estimate that's probably 18 months or 2 years old, and people are going to make more money, and they're going to pay that back. And I think they're going to get a bad taste in their mouth that, wow, that subsidy I thought I had, I've got to pay more for my health insurance now on my tax return. I haven't seen, by the way, the IRS hasn't issued the forms. CPA audience haven't seen the forms. Don't know if you go through this reconciliation process, it's pretty complicated. So we'll see how they have what kind of form they come up with to be able, because you have to take your subsidy, and you have to that calculation that I just went through. Somebody's got to go through that to figure out what the subsidy was and how much you got and how much you needed to get and then the difference. Another thing to watch out for going into next year, rate approvals. So in the Affordable Care Act, the Department of Health and Human Services can say that anything above 10% is unreasonable. The California Insurance Commissioner, Dave Jones, he's asked for a ballot measure so that he can have that same authority to deny increases above 10%. And generally speaking, we typically don't, we operate under, but what if medical inflation starts running above 10%? What if it starts running at 12 or 14%? What if inflation just takes off in general? And the health insurance industry is locked into Health and Human Services saying nobody can increase rates above 10%. What happens at that point in time? It'll be an interesting thing if that happens in the future. The Affordable Care Act also has what were called mandatory loss ratio provisions. And the combination of limiting rate increases and mandated loss ratios, it seems to me that the mandated loss ratios take care of the problem. That you don't need to have the additional, where did they come up with 10%? Why not make it 9%? Why not make it 11%? I don't know where they came up with a number that says, well, we're going to limit everything at 10%. Why not make it 6%? I don't know. They come up with these arbitrary numbers, but you'll see this, especially in California in the fall. There's going to be a big push to give the insurance commissioner this authority to regulate rate increases. Another thing that's going, and the IRS hasn't issued the date that this goes effective yet, but it was supposed to be in 2014. It looks like they're going to push this into 2015 now. There's a whole new slew of non-discrimination rules that are going to apply to health plans under the Affordable Care Act. And previously, these only applied to self-funded plans, but they're going to be expanded. And the reason I bring this up with this group is that we have a lot of CPA firms that I'm aware of where the partners, for example, have the Cadillac plan and it's 100% paid for by the company, and then staff has access to some lower benefit plans and maybe the contribution levels are different. I've worked at places where when people have their 10th year anniversary that their contribution level goes up. So in other words, if the employees are paying 80% of their premiums. When you work for the company for 10 years, then the company starts paying 100% of the premiums. A lot of those types of benefit structures, employee benefit contribution rates, access to plans, all that's going to go away under the Affordable Care Act when these new non-discrimination rules hit. And so if you're advising clients or your firm is doing some of these types of things, you're going to have to do a review on it and be compliant with the law. The penalties are pretty steep if you get caught in these non-discrimination rules. Like I said, they've already written the rules. They're just sitting waiting for the IRS to hit the button and say they're going to be implemented. And they're out in the Affordable Care Act, and it's been put into the code. So in the individual market, things to watch out for going into next year. We don't know what the premium rates are. So last summer, the insurance companies on the exchanges took a guess at what the rate structures were going to be. They didn't know who was going to enroll. Now they know who's enrolled. They're starting to collect some premium information. They might not have the best information, but we'll have to see what happens with the premium rates and the enrollment numbers. What I call paying for coverage. So a few weeks ago, the exchange issued a notice that out of all their enrollments, 85% of the people had paid, which meant that 15% of the people hadn't paid, so they had enrolled, but they hadn't paid their premium. I haven't seen a number come out after that yet, so I don't know what it is. But in individual business, we tend to run lapse rates anywhere from 1% to 3% per month. In other words, people don't pay their premium, or their account gets overdrawn, or the money's not there, or whatever happens, but we have lapse rates, and we'll have to see what the lapse rates are on those individual policies as they come due. It could be that between now and next fall, anywhere from 10 to 20% of that population lapses that originally enrolled, and we'll have to see who stays in and what they do. And then we've also gone to on the individual markets. In the exchange, what's known as a 90-day grace period. And most plans have a 30-day grace period. You have 30 days to pay your premiums. They've implemented this 90-day grace period. So folks have additional time to make their premium payments. This is also related to hospitals paying premiums. And I don't want to read through this, but I just want to mention. So, if somebody's in their grace period, they haven't made their premium payment, and they have an episode where they need to go in the hospital. Let's just say they need to go in the hospital and have $100,000 worth of work done. But they owe $300 in health insurance premiums. Well, it's probably in the best interest of whoever's going to, that hospital, to get somebody to pay that premium so that they can perform the procedures and they can get paid, and this person can get healthy. Well, the hospitals seem to have figured this out. And so they were in the process of setting up ways to pay heavy utilizers premiums. And the Department of Health and Human Services came out and said, hey, wait a minute, we don't want that going on. We don't want hospitals making subsidized premium payments for heavy utilizers. It started kind of a back and forth with the American Hospital Association, saying, their legal team writing to Health and Human Services and saying, you don't have any legal authority to stop this. And Health and Human Services says, well, we don't want it to happen. We don't want you to do this. And I thought when I first read this is probably, maybe somebody like the evil American Hospital Corporation, who always gets bad publicity on 60 Minutes and that kind of thing. And I started looking into who's actually providing these, which hospitals are doing this. And lo and behold, the first one I ran into was the University of Wisconsin Medical Center. So you've got a public University of Wisconsin who has a charitable foundation that's out there finding folks to pay their premiums to get them into the hospital. And so you're going to see this going on. I think this will be something that comes to the forefront over the next year or so, and you'll see a lot of this going on. And somebody's going to have to, whether it's Health and Human Services or the various state regulators, are going to probably step in and give some guidelines in that area. Cadillac Health Plans. It's always been out in the future, 2018. Although $10,200 sounds like a large amount to qualify as a Cadillac health plan, as you get up into your 60s, the premiums go up drastically, and $10,200 isn't all that much in the health insurance world. And the tax on those premiums above $10,200 is 40%, which is pretty steep. Either fortunately or unfortunately, a lot of big corporations, particularly the union plans, are all going to be affected by this. And I think their lobbying and their clout is going to get some relief in this area at some point in time. The market has already come up with some solutions, and I think the government's looking at those because they put out a law, and then the markets come back and said, well, we can either get around this or we can comply by using HSA plans, HRA, FSA solutions to get around these Cadillac plans. And so I think that this battleground will keep going until 2018. At the end of the day, there probably will be a Cadillac plan tax. I just don't think very many plans are going to pay it because they'll find ways to still offer the level of benefits without having it tied to a premium amount. COBRA is still out there, your continuation of benefits, but in the individual markets, we have guaranteed issue. We have lower premium rates. Why do we need COBRA? Somebody loses their job, they just go get an individual plan. What it means, though, is that the group plans are going to get selected against. Because if somebody can go get a lower cost plan, the only people who will stay with their group plan under COBRA are ones that are having ongoing medical care or they need to access a certain doctor. So we don't know what's going to happen to COBRA. It could really be done away with under the Affordable Care Act. We'll just have to wait and see. But as these large employers and union plans get selected against by COBRA, I think that we'll see that going away. And the same thing with coverage to age 26 for dependents. That was one that came in the Affordable Care Act very early. Why does a 24-year-old need to be on their parents' plan if they can go get an individual plan on their own? Well, it was under the old rating structures. There was a family unit, right? And the kid was just the 24-year-old was just part of that family rating structure. Well, as each of those adult children are rated as individuals, they're getting the same rate in the family structure or without. So there's not really an advantage to having them on the parents' plan anymore. So I think that it's redundant. We'll have to just see what happens. The underage 30s can go get what is called a catastrophic plan, which are very inexpensive, and they should be working with those. Last summer, the Group Insurance Trust put out an e-book called April 15th Will Look Like a Picnic. And it was a CPA's guide to a lot of the things that we just talked about. The book has been, I think, very successful. To date, we've had about 3,500 downloads off of the CalCPA or the GIT's website. We're going to be coming out with a new version of the second version of the book this summer. That will address, I mentioned those 38 law changes. Well, we have to keep updating the book. And so the second version will come out that will get everybody ready for 2015. And I'm sure you'll all get notices through clips or something else when the book is available, and you can go download that. In addition to the ebook, April 15th will Look Like a Picnic, we've also have some other documents and some articles that have been published that cover the same materials that we have that we were just talking about today. I mentioned there was an article about ACA displacement that we published last year. We've got some other things about the aggregate costs. Those are all available on our website, and you can link there from the CalCPA website. So there'll be a landing page that talks about the healthcare conference if you want to get more details. And we couldn't get all the details here today, but we have that set up. And then the trust is available to all CalCPA members to ask any affordable healthcare questions that they would like. We have an email line and a phone line that we can answer questions. Most of the questions we can answer, so we get calls and emails with questions for the firms themselves or for their clients. And many times, if we can't answer the question, we can send you on the right way. So please use us as a resource as you need to. And that's the conclusion of the formal. I can take questions if do we have time? Yes.
Question on the subsidy payback. If you file your return in 2015 and you have payback, will you show it again at the end of 2015 and when you file your return, or will you start having to pay increased premiums in the middle of 2015 after you filed your return for that year?
Right. Well, when you get to, it could be the never-ending cycle, right? So when you get to the beginning of 15, you're going to have to estimate your income again for 15. And that's going to calculate a new subsidy. So it'll be the same reconciliation as you come around and around and around. And that's why I said, if people start figuring out if they underestimate and get to those thresholds, maybe they'll have to do something about that.
And if you don't file timely, will you have to pay the penalty if you haven't paid that by April 15th, or is that?
I don't know the answer to that one, but all the individual mandates and the penalties on the individual mandates, the IRS's enforcement rules on those are very limited. Like there's no penalties and interest on individual mandate Affordable Care Act penalties. So they can say that you owe it, but they don't really have an enforcement to penalize you or to apply interest to those.
But I mean, they would take it from your refund, right? If you have a refund.
Oh yeah. Well, they'll get it if they owe you money back, they'll take it.
But, so when you're calculating your tax return, you'll go into calculating the amount that's due.
Well, like I said, I haven't seen the forms yet, and I don't know how they're going to do it, but I'm assuming they're going to have an additional form, and it'll say, we know that you were having a subsidy, and maybe they pre-print an amount, or the IRS is going to issue a form that says, here's the amount of your subsidy. Because most people wouldn't know the amount of their subsidy. How would they know? They're just making a premium payment.
Will there be a 1099 or something like that?
I think either the health insurance company or the IRS is going to have to issue some document to them to tell them what their subsidy amount is.
There was a question here.
Yes?
Just wondering on the Cadillac plans, is that for just plans that employers offer, or if an individual has a plan that exceeds $10,000 a year, is that a tax that the individual has to pay on their own plan too, or is it just the employer?
Yeah, I believe it's any plan that's above $10,000 too. Right. But where it really affects is when we get into the large employer plans, because many union plans, not all, but many union plans use what we call super composite rates. So they don't divide their plans up by age groups and family size. They just have one rate. And if that rate gets above the $10,200, because typically they have very, very rich or high benefit plans, that's where that tax comes into play. And people say, well, what does the government care? Why does the government care that companies are offering high benefit plans with high premiums? Why wouldn't they encourage employers to spend more money and offer better coverage to the employees? Well, that's all tax deductible to the employer. And by limiting that, they're pulling back on that tax deduction for those employers. And that's why they need that money to have the Affordable Care Act work. So that's the motivation behind it, is to limit the employer's deductions for health insurance premiums to a certain level. All right? Yes?
Hey, Ron, you talked about gaming the system on the premium subsidy reconciliation paybacks. And my understanding is that that would work within the federal poverty limit levels because you have the cap there. But if you estimate under 400% of federal poverty level and you end up over that, that's worst case scenario. There is no cap there. You're just paying everything back. You're
absolutely right. The cap, if you look at the fourth bullet point, more than 400% of federal, you repay the entire subsidy. Right. So if you were a family of four and you estimated that you were at 90,000 of income and you actually made 100 and you crossed that threshold, which is what, 94,000 some odd 250 or whatever it is, you pay the entire subsidy back. There is no cap. Anybody else?
You mentioned that health plans might have to provide the total subsidy dollars to the members for this tax filing. Are we waiting for the IRS to release that? Or I'm a health plan worried about having to provide this by the end of 2014.
Like I said, I don't know where that number is going to come from, but the taxpayer is going to have to get it from somebody. And so whether they issue a document, some kind of year-end summary, I don't know who that's going to come from, whether it's going to come from if the IRS is going to say we want the health plan to issue this, or if the IRS itself is going to issue it, or Health and Human Services is going to issue that. But they have to get that number from someplace. And I haven't seen where that came from yet. I'm sure we'll hear, in the next 6 or 8 months. Maybe by February of next year they'll tell us. Yes?
If the deduction for the employer is the motivator for the Cadillac tax plan, does that mean plans offered by governmental, municipal, county entities and nonprofits are exempt?
Well, if you could repeat the question for the web
Yeah,
audience.
you're asking if there are plans that are exempt from the Cadillac tax, and I believe that there are plans that are exempt from it, but I don't know the entire list, and I think some of the ones you mentioned are in those categories. Like I think Congress exempted themselves, but I could be wrong.
Always.
There was a question from the web. So the question is asking, can you explain what is the definition of a small group?
Okay. Small group or small, under the Affordable Care Act, they call them small employer plans. And so that's from 2 to 50 employees. Now, that number expands to 100 in 2016. And the feds just recently, within the last couple months, exempted the employers from 50 to 100 from all the employer mandates in January 2015 till 2016. So let me give you an example of how this would work. Let's just say you have 75 employees. In January of 16, you will have to purchase a small employer plan under California's small employer. So it'd be all of the age-banded small employer plan, where right now you could go to the market and purchase a large employer plan that would be fully underwritten by the carrier, and you would have the family tiering structures of employee, two-party family structure. In 2016, that 75 life group will be considered a small employer plan, and it'll go under all the so small employer will go from 2 to 100. Right now it's 2 to 50. It'll go to 2 to 100 in 2016. And those 50 to 100, they were exempted from the employer mandate that goes into effect in January of 15. They've moved that to January of 16. And they did that about 2 months ago. Some people think it's election year politics. You're moving a population out a year. It's certainly a relief for those folks.
So if you're small employer, when do you have to start your own company plan?
Okay, so small employers under 50, there's no mandate to provide coverage. You do not have to provide coverage to your employees if you're under 50. Now, the government does offer to certain employers a tax credit if the employees meet the income requirements. So I can put that up on our website. There's a chart that shows what the subsidies are, but the subsidies go away at the end of next year anyway. So there's really no incentive other than the tax credit for this year for a small employer to offer a plan. There's no mandate. There's no penalties.
However, I think there is an individual mandate that on your income tax return, you will have to specify whether you have insurance coverage or not. And if you don't have insurance coverage for a tax year 2014, you are going to be assessed what they call a penalty of $95 or 1% of your income, whichever is greater. And it escalates each year.
Yep. And one of our speakers later today will show you that chart and take you through that, I think.
Okay, let's thank Ron. That was great.